Okay, well, for the sake of time and all of the great information that we're about to present, I want to go ahead and get started. So, hello everyone, and welcome to today's session of Addiction 2021, Treating the Whole Person, hosted by SafeRx Mendocino Opioid Safety Coalition. SafeRx Mendocino Coalition members are medical professionals, educators, law enforcement, and community-based organizations taking a community approach on preventing and reducing opioid use and stigma, and promoting holistic and comprehensive treatment for a healthier community free from opioid misuse. If you're interested in joining our coalition, please add your email in the chat, visit our webpage for more information at www.safrxmendocino.com, and find us on Facebook, Instagram, and Twitter. So a few housekeeping items. If you have any questions on how to receive continuing education credits, please privately chat one of our moderators, myself, Buffy Barassa, and Joanne Gamble. Mute yourself during the presentation, please. This session is being recorded. There will be an evaluation link in the chat box at the end of our session. Please take the evaluation and let us know how we did. We'd love to hear from you. Your feedback is a requirement to obtaining CEUs and CEs, and we will present you with a certificate of attendance as well. So I would like to introduce today's speakers. Dr. Greg Greenberg completed his undergraduate studies at UCLA in psychology and neuroscience. He attended medical school at Ohio State and completed his family medicine residency in Columbus, Ohio. He moved to Reading to work at a local community health center, eventually transitioning to full-time work in emergency medicine and as a hospitalist, including being the medical director of 3 different programs. He helped the Reading Rancheria open a clinic where he began his practice of addiction medicine, and he continues to work in emergency, hospital, and addiction medicine. He is now working with the Pinoleville Pomo Nation as the medical director of an opioid treatment program in Ukiah, California.
Well, thank you, Buffy.
Thank you.
So first, hi, everyone. As you can see, I have a little bit of career attention deficit disorder. I tend to do a little bit of everything, so keeps things interesting in my life. So I'm going to play the presentation that I have recorded, which hopefully will work okay. If there's any problems, we'll see, and then we can do questions after that. One thing I didn't put in there, just so I throw it out there, is the disclaimer that I do not have any financial relationships with any company whose primary business is producing, marketing, selling, or redistributing healthcare products. So that's the mandatory CME disclosure. I will say my conflicts of interest are, one, I really believe in what we do as far as addiction medicine. So I have a strong belief in what we're doing and that we help save lives. And as Buffy mentioned, I'm also working with an opioid treatment program in Ukiah, which I think is going to make a huge difference for our community as well. So first, let's see how good I am with the technology and sharing my recording, and let's see if I can do it without screwing up. Let's see. Give me just one moment and I will get that going. Hi, everyone. My name is Greg Greenberg, and I'm here to talk a little bit about addiction. I'm first going to start talking a little bit about the background because it's very important if we're going to treat people with substance use disorders, understanding how they got there and why they got there and why the brain does what it does. And then more importantly, I'm going to talk about evidence-based treatments that we have for substance use disorders. So kick back, relax, and enjoy. At the end, I will be live again, and there'll be time to answer questions with question and answer session. So no good presentation starts without the narcissistic physician talking about himself. So I've been a physician for about 20 years. I started out in family medicine at a community health care setting. I've also worked in emergency medicine and as a hospitalist. About 5 years ago, I started working with a Native American clinic, and that's where I really started doing addiction medicine. And after treating addiction in so many different areas and not really having much in the way of success, I found addiction medicine to be very rewarding because I finally had something to offer a lot of my patients that I never really had to offer before. I started doing consultations in the hospital. So I did addiction medicine consultations for hospitalized patients and for patients in the emergency department. I continue to do telemedicine for addiction, and I work with New Life Clinic to open an opioid treatment program in Ukiah that should be unlike anything else that I've worked with before, and something that will be very unique within California. So one thing here is I do talk about stories a lot. I have changed the details for HIPAA reasons, but I think stories are very powerful. We learn by stories, and it's very important to understand really where a lot of our patients come from. So I do tend to tell stories, but keep in mind I have changed details to protect the innocent. So one thing that's very important, and this has been discussed previously in other sessions, is your words matter. That addiction has a lot of stigma that goes along with it, and that stigma tends to be a barrier for people accessing treatment. So when you refer to someone as an addict or someone as a junkie, you're labeling them. You're making that person's whole identity, versus a person with a substance use disorder is a person with other facets of their life that happens to struggle with addiction. They're not dope sick, they're in opioid withdrawal. They're not a junkie. It's very important because many of the people that we see have been stigmatized, not just in society, but also by the healthcare system. Most people who I talk to in the emergency department for issues with substance use disorder have had bad experiences already with the healthcare system as they've been treating poorly because of their addiction. So it's very important that we watch our words when we talk to colleagues and when we talk to patients, because when we say substance use disorder, when we say someone with an alcohol use disorder, we're really showing that we care about that person, and we're not saying that their addiction really identifies everything about that person. So it's very important for you to get credit that you have to memorize everything that's on this slide about addiction. Otherwise, you'll fail. Just kidding. But the point of this slide is not even to read the whole slide. It's to understand that addiction is a very complex process. So someone may say, I'm addicted to Norco because I need to take more Norco to get the same effect, that I have withdrawal when I stop taking Norco. That's not addiction. That's just like saying that I'm addicted to metoprolol because when I stop taking metoprolol, my heart rate goes up and my blood pressure goes up. That's not addiction. Addiction is a very complex biopsychosocial, neuropsychiatric process that involves all facets of people's lives. And it's very important to distinguish the two, because a physiologic response to a medication is not addiction. Someone who is taking methadone and taking it every day and doing what they're supposed to and working and not having relationship problems is not addicted to methadone just because they have withdrawal when they stop taking it. So that's also very important that we distinguish addiction from a withdrawal syndrome. Got to include some nerdy stuff, and of course I have to include The Simpsons. No good discussion about addiction excludes the nucleus accumbens. Everything addiction medicine really happens to be that dopamine reward center, because this is where addiction is at. This is really what happens, and understanding this is very important to understanding addiction. So if you think about your nucleus accumbens, that's the dopamine reward system in your brain. You normally just have a normal level, 100%. And throughout your day, that varies. So maybe you've had a really good day, you did something, you went to a football game, you had a great time, you had a wonderful meal, you had sex. The highest you're going to get is about 200%, even if you're combining all those things at the exact same time, which could be challenging. So normally you're fluctuating between maybe 100% to 200% of that normal level. Now, let's say it's a Monday, you have to listen to some boring lecture about addiction, you had an argument with your spouse, your dog is sick. You may go down to about 80%, but those numbers don't get really that low. So there is normal variation that happens here. Now, what happens with drugs is this is what they're affecting. That dopamine reward center, that's the area of your brain that is being affected to say, hey, this is really good. That system normally tells you to do things as an organism that are going to be beneficial to you. finding shelter, getting comfort, getting food so that you can continue to thrive as an organism, having sex so that you can reproduce as an organism. Now, when you add in substances, you may get a little bit of a high with nicotine, that you may feel good for a really short period of time that you normally wouldn't have. Cocaine, you're going to get way beyond anything in life. So even when you just watched your favorite sports team win, back before COVID, when you could actually watch your sports teams win, and you had the best sex of your life and you had an amazing meal, and yes, I have to keep adding those things in. Even when you've had that, cocaine gets you far above anything you can normally get like that in your life. Now you look at heroin, same thing. You're getting 3 to 5 times what you could normally get just throughout normally in life. Amphetamines, now this is the one that's really scary. You're getting 11 times what you could normally get as far as those baseline levels. You're getting a rush far higher than anything else, anything in life can get. So you are getting this amazing experience that your brain is saying, wow, this is incredible. I got to do this again. This is what I really need to keep doing. And we know study after study shows that in animals and in humans, once we get that, we try to chase that. We try to go for that same kind of high. But here's the problem. We never get there again. So we may reach that high, but as we continue to use that drug or use that substance, we're not getting the same high. You're chasing that same high that you had before, but you're maybe not as high, and then the next time not as high. Even worse, what happens is your baseline doesn't go back down to 100%. You're dropping down lower. So you may be dropping down to 95%, 90%, 80%. So you're walking around now on a daily basis. You know that feeling of that Monday when you had to listen to me talk for half an hour and you're having a bad day and your dog was sick and everything else? Well, you feel like that all the time. You feel horrible, but then you're dropping down even lower than you would. 70%, 60%, 50%. You're getting levels far below anything normally would in life. You are feeling horrible, and your brain knows the only thing that's going to make you feel good again or even feel normal again, and you'll hear this from patients, is I use this drug to feel normal. You feel so crappy without that drug that you're just starting to use it just to feel normal again. And this is the problem. Your brain is then telling your body, I need this to survive. I cannot function. I cannot get out of bed. I cannot move unless I have this drug. And so, or the substance. And so you more and more are getting to this point where your brain, even though your prefrontal cortex is saying, this is bad, this is causing problems, this is causing relationship issues, I'm going to get another DUI. That deeper part of brain says, screw you. This is the only way I can function. This is the only thing that's going to get me functioning in life. So this is basically just a graph again of what I just said, and it shows you, especially you look at methamphetamines, because this is one of our challenges, and unfortunately there's not an easy answer for this. That spike and that feeling beyond anything else you can get, this is what we're trying to fight, and this is a hard thing to fight. So what causes addiction? Of course, I have to include Homer Simpson because my biggest problem are carbohydrates. So genetics, we know genetics play a role, but it's very difficult to sort all of that out. And the reason is, when we look at it, if someone says they have a family history, their brother was on cocaine, their mom had an alcohol problem, their dad had an opioid problem, well, we don't know how much is nature versus nurture, or do we? Yes, I have to throw in the 80s references, but when you look at nature versus nurture, the best studies that we have are twin studies. There are plenty of studies where there were twins separated at birth and went to other foster families or adopted out. And so we can see how much of this is genetic because they look at identical twins versus fraternal twins, and they can identify from there how much of a component there really is in all this. And when you look at the twin studies, most addiction, about half of it, actually relates to a genetic component. So probably all of us here know that ACEs are very important. And no, I'm not referring to Ace Ventura. I mean adverse childhood experiences. The more adverse childhood experiences someone has, the more likely they are to have a substance abuse or substance use disorder. And this is a very important factor. All right, I promised you some stories. So this is based on a patient that I saw in the hospital a few years ago. So I was doing my usual interview. This person was hospitalized for a life-threatening infection that they had from injecting heroin. And so my first question was, I asked, how was your childhood? And he said, oh, my childhood was fine. And then I asked, any family history of addiction? And he said, oh yeah, my mom, she was a alcoholic and she was a meth addict. But you know, we didn't really hang out with her. We went into foster care when we were 2 years old. So of course he minimized his childhood prior to that. And as we're talking more, he said, oh yeah, you're going to love this. This one's really bad. So he said, you know, he was in foster care from one foster parent to another. And then when he was 9 years old, his mom decided that she was going to get clean. And yes, I'm using the stigmatizing language, but it's language the patient explained to me, but that she was going to get clean and she was going to get her kids back. So she did that. She got off of meth. She got off of alcohol. She jumped through all the hoops that she needed to. She got the kids back. And he said after 6 days, she took them to McDonald's and she got them some food. She sat them down at the table and she left. Didn't say anything, just left. She just basically just couldn't handle it anymore, couldn't take the kids, disappeared, started using again. They never saw her again. Then I asked my other question, which is, when was the first time you took an opioid and what was your response? And then he laughed and he said, oh, this is a great one too. He said, when I was 11 years old, I had a headache. So my foster dad decided to give me a Norco for the headache. And he said, I loved it. I had energy. I felt great. This is the most amazing thing I had ever felt. And he said, from then on, anytime I could get a hold of an opiate, I would. And so this is how his substance use disorder started. And when you think about it, sometimes a substance use disorder can be seen as a predictable response to a set of circumstances. He had a genetic predisposition. He had all these adverse childhood experiences. And then all of a sudden, when some idiot foster dad gave him an opioid, which he shouldn't have, that gave him that feeling of, wow, this is great. My life has sucked until now. This is what's going to make my life better. This patient, I'm telling you, unfortunately ended up dying later from a substance use disorder. So this is another one that's important to remember, is that we caused opioid use disorder in many of our patients, that we gave people medications and told them, this will help you. This is what's going to make your life better. This is what's going to make you feel better. I have many patients who came to their doctor, had pain issues, were placed on opioids. They had escalating use of those opioids. And then all of a sudden, when there were any kind of red flags, their physician said, oh, you're a bad person. You're a junkie. You're an addict. I'm not prescribing to you anymore. Left them high and dry. And then they go and get heroin, which is really cheap. And then their life spirals even further out of control. We caused this problem for a lot of people. Hopefully all of you know this by now, but it's a chronic disease. When someone has a substance use disorder, that doesn't just go away. And we should expect relapse. We don't take someone with diabetes and all of a sudden they forget their dose of insulin, they eat a couple Snickers bar and tell them, you're a piece of crap, I'm not treating you anymore. This is your fault. You chose to have diabetes. You chose to have this problem. Well, we need to see substance use disorder just like any other chronic disease. And there will be relapses. There will be times where it does better. This will be a challenge for people, and we need to use that chronic disease model for treatment. So treatment options. This is basically, which essential oil do I use for my substance use disorder? This is just a quote I always have to have in here. Cocaine is God's way of telling you you're making too much money, from Robin Williams. So first, let's talk about stimulant use disorder. What medications are effective for this? Now, in reality, medications are not all that effective, not like they are for opioid use disorder, but there are some adjunctive medications that can be helpful. As you may have heard, there was a study that was published in January of this year where they looked at the combination of a fairly high dose of bupropion along with injectable naltrexone. And they did show a substantial reduction in the use of methamphetamines, as well as an increase in abstinence. The number needed to treat is still fairly high, and this needs to be done in conjunction with other treatments. But this is promising that there are some medications that can help. There's a couple studies on mirtazapine that have shown some benefit with methamphetamine use disorder as well. Those are primarily from Dr. Coffin in San Francisco, but it's also been reproduced. And so that's something that may be helpful. Topamax is one of those medications that people have really hoped would be helpful. Hasn't panned out in studies. Anecdotally, there may be some benefit. Bupropion is another one. And when you look at the most recent study, it makes sense that bupropion may be helpful as well. But really, most of this involves therapy. It involves changing things in life, working on triggers, working on the environment. Contingency management is one of those things that's really shown some of the most benefit, although it's really hard because of some of the restrictions that we have in place to really roll this out in a lot of different facilities. The idea of contingency management is you're giving a reward for behaviors that you would like to see. I mean, this is basic operant conditioning. So you're giving rewards when people are having a talk screen that doesn't show methamphetamine, or they're showing behaviors of less use and things like that. And these can be even small rewards, and it tends to be effective. The biggest thing, though, is changing the environments, working on the triggers, working on the things that led to the substance use disorder as well. Alcohol, we always go back to our good friend Barney. So what are Barney's treatment options when it comes to alcohol use disorder? Well, this is very similar to most of our other substance use disorders. Outpatient treatment does work. The mainstay of treatment are the social programs like Alcoholics Anonymous. I have quite a few patients who are quite successful with that, and often they need meetings every day to stay abstinent from alcohol or reduce their alcohol use. In addition to that, there are other options. Some people don't like AA. There's something called Smart Recovery that they can do. There are other programs with other types of meetings. There's cognitive behavioral therapy. There's a lot of different therapies that can work. As I often tell my patients, though, what's not effective is doing nothing and expecting that to have a different result. There is residential treatment. The idea is you get away from the triggers, you have that support, you have the peer support, you have frequent therapy. There's non-medical detox, and that's available in most of our communities because we don't have medically supervised programs in a lot of our rural communities. So that usually means that they're going to be in an environment where they have really non-medical people there that are helping and supporting them. And hopefully this is also with the help of a physician or a provider prescribing adjunctive medications, because they are much more likely to be successful if they're also taking medications that will help. What medications work? There's a lot of different ones out there. Most of you have heard of disulfiram or antabuse. It only works if someone's taking it, so it's easy for people not to take that. Gabapentin is one of those that I've had a lot of experience with, because in the emergency department, we often see people come to us in alcohol withdrawal. And so I'll often not want to put them on a benzodiazepine such as Librium, because I'm concerned about them going out into an uncontrolled environment and then drinking and taking that benzodiazepine. Gabapentin tends to be a safer alternative. I use it in the hospital as well. I usually use the dosage of 300 milligrams 3 times a day. There's another study that showed 600 milligrams at night with 300 milligrams the other 2 doses. I do try to keep it as simple as possible. It does help with the withdrawal symptoms, and there's some studies that actually show a dose response to the gabapentin or Neurontin as far as the reduction of alcohol intake. So 300 milligrams 3 times a day is effective. 600 milligrams 3 times a day is even more effective. Usually I work my way from the 300 to the 600 as an outpatient, and it can be very effective in reducing alcohol consumption and reducing cravings. Now, naltrexone is our standard, really, when you look at MAT. It blocks opioids, so you can't use it for people who have opioid use disorder, especially if they're on MAT. But it decreases that craving, and you go back to our friend, the nucleus accumbens and the dopamine reward system. It's probably working by blocking that, and that's how it blocks cravings. It tends to be fairly effective as far as decreasing the amount of drinking when they do drink and increasing the amount of abstinence as well. There's other options. Carbamazepine can be used for withdrawal, can be effective as well. Acamprosate is one of those that came out a while ago that showed some promise, but the promise hasn't quite delivered. So benzodiazepine use disorder. really my excuse to use this slide with Gary Busey. So this is very similar to alcohol use disorder. The medications tend to be similar as well. I think the bottom line in this one is it's very difficult. Anybody who's trying to wean someone off of benzos, especially someone who has been on benzos for a year or several years, it is incredibly difficult, especially as they get to the lower doses. Adjunctive medications can help. This is where I have used gabapentin adjunctively as well. You just have to understand that this is very challenging, and usually you want an experienced provider doing this because it takes a lot of support, it takes usually a lot of counseling as well, and it's really never easy. So now let's talk about opioids, because this is one of the things that has really driven up the overdose deaths and has, for rightfully so, gained a lot of our focus lately. So opioid use disorder criteria, the reason I put this here is to again explain that tolerance and withdrawal alone don't mean that they have an opioid use disorder. So if someone's on medications for pain and they have to take more to get the same effect, and they have a withdrawal syndrome when they're not taking it, that doesn't mean they're addicted. You look at these criteria. Addiction really has to do with craving, has social issues, occupational issues, continued use despite having physical or psychological problems related to it. Opioid use disorder is much more complex than just having a withdrawal syndrome. So let's talk about treatment options. This is my favorite, inpatient medically supervised addiction treatment. I know it really does exist somewhere, but I do think it's like unicorns and the chupacabra, the Easter Bunny, and the Loch Ness Monster. So residential treatment, let's continue my timely pop cultural references with One Flew Over the Cuckoo's Nest. But basically, this is where you have a supportive system where people are in an environment that's much more controlled. This is one of the most important slides of all of this, because I can get someone through withdrawal where they're not having any withdrawal from their opioids. They're done with all the issues related to that physical withdrawal. Even with that, 30 days past detox, only 20 to 15% of them are still abstinent from opioids. Opioid use disorder without MAT is a setup for failure. It only works maybe 10% of the time within a few months. The numbers are really bad, and that's because of what it does to the nucleus accumbens. So if you're sending someone to a residential program and they're not on MAT, you are setting that person up for failure. Medication-assisted treatment, also known as medications for opioid use disorder, or whatever it's called this week, is the mainstay of treatment for opioid use disorder. So buprenorphine, also known as Suboxone or Subutex, depending on what kind you're getting, and methadone are both opioids. Naltrexone blocks opioids. And these medications keep that nucleus accumbens from having that feeling that you're feeling so horribly that you need that drug to survive. So the first two stop the cravings by its effect in the nucleus accumbens. Naltrexone does as well, but it operates a little bit differently. This works far better than other forms of treatment. If you try just abstinence alone, if you try just NA or residential treatment programs, like I said before, you're setting the patient up for failure. This is not substituting a drug for a drug. The patient is not generally getting high on this. You don't see the maladaptive behaviors, the psychosocial consequences, the other consequences that people have if they're in a program and using these medications appropriately. They are not addicted to methadone or Suboxone when they're part of a program and taking them as directed. So methadone is a typical opiate. The more you use, the more effect you have. And eventually you can use enough to the point where you stop breathing. It's taken daily for opioid use disorder, although it's more of a 3 times a day for pain just because of the way it works. It has a long half-life, but the pain effects, the pain mitigating effects really only last about 6 to 8 hours. There is a risk of overdose from respiratory depression. There's a risk of prolonged QT as well. This can only be prescribed at an opioid treatment program for addiction. It can be prescribed for pain elsewhere. It can be given in the hospital or in the emergency department, not as part of an as part of a opioid treatment program, and this is very important. It's generally well monitored. You have to be very careful with this with other sedating drugs because they can have additive effects. Buprenorphine, which we know, Suboxone, which tends to be our first line for treatment for opioid use disorder. It's combined with naloxone as a pill or a strip so people don't inject it. So when they take it by mouth, generally the naloxone has very little actual effects. We tend to avoid the naloxone combination product in pregnancy because of the unknown effects on the fetus, although that kind of depends. There are some communities, including where I work in Reading, where we still give that because of the street value of Subutex or buprenorphine alone, and because it can be abused or diverted. It's really a judgment call when it comes to that. It is a partial agonist with a high affinity for the receptor. So it really it does not have a full effect of the receptor. It only has about a 40% effect at the receptor. But what it will do is it'll push off other opioids. So if they're on methadone and you give them buprenorphine, buprenorphine will push the methadone off of the receptor, but it only has 40% effect. And so that's how you get precipitated withdrawal. If they have a full agonist opioid on board, and that includes heroin, that includes morphine, other ones, that buprenorphine will push those off of the receptor, but have less of an effect and actually cause withdrawal, versus if they're in withdrawal, it has the opioid effect, takes away with the withdrawal. It also takes away the cravings and has the other positive effects that you hope for. It has a respiratory depression ceiling, meaning it will slow down people's respirations, but generally not to the point of them not breathing. So you can give them a ton of buprenorphine, but it only has a limited effect because of that partial agonist that it is. Methadone does not have that, so you have to be much more careful with methadone. If you're treating pain as well, buprenorphine generally has to be split into 3 times a day dosing, similar to methadone. Naltrexone, also known as Vivitrol for the shot, it blocks opioids and can block cravings. If you look in the study, if you can get past that initial washout period, it tends to do actually fairly well, somewhat similarly to opioid agonists. But the problem is most people fall out before they can get to that point because it's very difficult to stay abstinent, maintain that abstinence for them to get on the Vivitrol shot. But there are certain populations, including those who are incarcerated, that this may work well for. It also, like I said, works well for alcohol use disorder. Here's a visual reinforcement of what we just talked about, where naloxone is an antagonist and has no opioid effects. Methadone has a full agonist opioid effect, and buprenorphine has a partial effect that even with increasing doses, you don't get increasing effects at the receptor. So the really important question here is why MAT? Why are we giving people free dope? Obviously, I say that tongue in cheek, but the reason is because we see a change in behavior that ends up resulting in positive behaviors not only for themselves, but for society. There's less criminal behavior, there's return to work, there's improved social structure. People are actually either getting their kids back or taking improved care of their kids and not causing harm. They're not getting and transmitting hepatitis C and HIV. They're not getting endocarditis and ending up in the hospital. We see not just a reduction in harm to the patient, but we see a whole lot of outcomes that result in improvement for the patient. So quick disclaimer here, this is a little bit of a conflict of interest just in the fact that I will be the medical director of the New Life Clinic, but it's a conflict of interest because I believe in what we're doing, and I've been really working towards improving access to treatment. And the New Life Clinic will be opening June or July in Ukiah as an opioid treatment program where we can treat a wide breadth of addiction issues. We will be an opioid treatment program, meaning we will have methadone, we will have buprenorphine, we will have naltrexone, but we'll also be able to address other substance use disorders such as alcohol use disorder, methamphetamine use disorder, stimulant use disorder, and other issues related to that. And the idea here is it's not a one size fits all. We can tailor the medication, we can tailor the treatment to what the patient really needs. This will be run by the Pinoleville Nation, but this will be open to all members of the community as well. And I think this will really be a huge benefit to our community in providing access to treatment for substance use disorder. So I give out my email address and my cell phone number to anybody who will listen. And the reason is I really believe in what we're doing. And I do have some experience and some expertise in this area, and then I'm more than happy to advise and guide people. I really want this out there to as many people who can to treat opioid use disorder in as many settings as possible. I treat people when they come in the ER, I treat people in the hospital, I treat people in the outpatient setting, and we really need to have an attitude of low barrier to treatment and no door is the wrong door to get treatment. And anybody who has any questions, if I can't help you, I can find people who can help you. I'm really just out here to spread the word and get as many people helping treat substance use disorder as possible, because this is an epidemic and this does require as many people doing this as we can get. Thank you guys for your time, and the next step will be question and answer. All right, and now I'm back.
Wonderful.
So I have one comment on myself now, but one thing I want to just kind of add too, because we're talking about the stigma part. This month, I've seen a bunch of new patients for substance use disorder, and it's kind of the wide range of alcohol, methamphetamines, opioid use disorder. And I really have seen pretty much every nationality and socioeconomic status. So I've had a whole bunch of very diverse patients because I'm doing telemedicine that covers throughout California. And substance use disorder does not know boundaries when it comes to ethnicity, when it comes to politics, when it comes to socioeconomic status. I have several working professionals who I'm currently treating. I have seen a lot of people from all the way from just recently getting out of prison to currently practicing medicine, and so it could affect anyone. And so this is a disease that really we have to understand that affects really people of all walks of life. Okay, now I'll shut up.
Thank you, Greg. We are very good, very happy with your presentation. I've already got a few questions in the chat box, and so if you have questions, please put them in the chat box, and we'll try to get to all of them. So first of all, I just want you to know you did an amazing job, and I'm so glad to hear about this. And I think they're talking about the New Life Clinic. The next question lines up as, is avoiding friends who are using, while it can be an important thing to do, can also result in a lack of social supports. What do you suggest for closing that gap?
So that is a great question, because one of the things you'll hear a lot about in addiction, the opposite of addiction is not recovery. The opposite of addiction is having social support. And that's a huge part of recovery, is rebuilding that social support. Now, for a lot of people, that's a very maladaptive social support when people they've been using with, or like one of my patients, his brother is still using heroin, and he still sees him, and it's constantly a trigger. I'll give you the evidence-based medicine answer, which is we don't have great evidence. So I'll start with the scientific part. I'll tell you the practice-based answer, which is at first, it's really hard for people to avoid triggers, and especially with methamphetamine use disorder. It's such a trigger that I see of people they used with before, or something along that line. So early on, especially, I really try to get people to build positive social structure, see if they can build friends with people in recovery, and that's where a lot of these programs really help, if they can build those positive ones. The other part, though, is we talk about avoiding triggers, but eventually life has triggers. Like, especially you look at my patients with alcohol use disorder, you cannot escape alcohol. It's everywhere. And so learning to manage those triggers is a huge part of treatment too. So I think a lot of it kind of evolves that at first, I tell people to delete their dealer off of their phone Sometimes that works. Most of the time they find a way to find it. I've had people even go back to their phone records to try to find those numbers too. People can get really creative when they get desperate. But as time goes along, part of it is also managing those triggers and managing to build a positive social structure. I don't know if that really answered it, but hopefully it just helps.
Thanks, Greg. And so our next question is will New Life Clinic be an outpatient or an inpatient program?
So New Life Clinic will be outpatient. It's an opioid treatment program, which is methadone, what people refer to as methadone clinics. I hate that term because it's not just about methadone. Methadone is one of the things that they can do, but one of the things I've noticed in addiction is I've worked with community health centers, I've worked with a tribe, and so we focus on buprenorphine or Suboxone, and then you look at the opioid treatment programs and almost everybody's on methadone. Like in Reading, for example, they have 480 some patients, and I think they have 18 right now of those that are on buprenorphine. Part of it is patient self-select, but part of it is also the fact that if that's what you're doing all the time, that's what people end up doing. And so methadone has higher regulations where people have to basically come in for their dose every day, and they have to do that consistently for quite a while before they get take-home doses. And so it'll be outpatient, but it'll have that opportunity for more or less intensive type of treatment based on what the patient needs too. So we're hoping to build kind of a more ideal clinic that manages what the patient really needs as far as the outpatient stuff.
Perfect. And so next, can you talk about the new change for OUD?
Well, thank you, Katie, for that question. You lobbed that one up for. So as some of you may know, that there was a right before Biden took office, looks like is all physicians, nurse practitioners, PAs will be able to prescribe without the X waiver. And that I don't know when that takes effect. I have to actually look more at the details, but it's going to be that up to 30 patients can be treated without an X waiver. And that's the way it should be, because I can prescribe Dilaudid without an X waiver, but I can't prescribe buprenorphine, a much safer medication. So it's these kind of old archaic rules and some of the fear that people have of treatment without understanding it that's really blocked things. So this is going to be a huge development. So basically anybody who can prescribe, has a DEA ability to prescribe opioids, would be able to prescribe buprenorphine for substance use disorder. And this will be a huge thing too. So hopefully all of you will be getting emails finding about this. If you're on anything that's giving updates, I got a whole bunch of emails yesterday. So this will be a huge development for us.
Thank you. And so the New Life Clinic, what kind of insurance are you accepting?
I will say that I'm hesitating because we're still developing all of this stuff. Medi-Cal and Medicaid are our biggest focus, and so partnership is the one who's delivering Medi-Cal. And you know, what's interesting is that we have such a screwed up healthcare system. You're going to get me on a tangent, but we have such a screwed up healthcare system that people who are insured tend to have a lot more barriers and a lot more problems, that the insurance companies make this very difficult. And it's very unfortunate that that's one of those things that we've had to deal with. Most of the patients I see with substance use disorder issues don't have private insurance. This is one of those things that it's very complex in managing it, in contracting with them and everything else. So that's why at first our plan is dealing with Medi-Cal and Medi-Cal and Medicare. And then we'll figure out the rest. So I'm intentionally vague because there's a lot of complex things that I still don't entirely understand.
Thank you. So the next one is from a personal experience, that they know multiple people who have been on Suboxone for over a year. One has been on it for multiple years. And at what point is it considered addiction? In my opinion, it seems like they are using it as a crutch, which is not a good thing.
Okay.
And I believe that they're talking about is the MAT.
Yeah. So that is a perfect question because it's one we get a lot. So we hear you're substituting a drug for a drug, you're just getting addicted to another substance, or it's just a crutch. And I totally understand that because before I started doing addiction medicine, it didn't make sense entirely to me as well. But I do think I've started to understand it at least a little bit better. So the first part is substituting a drug for a drug. So there's a difference between addiction and taking a medication. So that's kind of the analogy I used with metoprolol. Sometimes we're dependent on medications, in that if you look at it, the changes that happen to the brain when someone has a substance use disorder, you never go back to normal. You will not see someone who had a really bad addiction who will say, oh yeah, that's not even a thing for me. I never think about it. It just changes you. It just really affects people. And it's something that people struggle with all of their lives. So if I have a patient who's coming to me and they're taking Suboxone, and let's say they're taking 16 milligrams a day of Suboxone every day and they've been on it for 2 years. They're not getting high on the Suboxone. They're not feeling the Suboxone. They're not engaged in behaviors that they were when they were addicted, such as breaking into cars to get their Suboxone, putting themselves at risk, not taking care of their children, not going to work. So I expect most of my patients, and I do see most of them on Suboxone, being functional. They get functional relationships, they go back to work, they're not engaged in illegal activities much of the time, or a lot less frequently. And so being on the medication is not the same as addiction. Crutch, it kind of depends on how you look at it. So if you look at the old school NA, they'll tell you you're not clean if you're on Suboxone, or you're not clean if you're on Methadone. That tends to be a behavior that interferes with treatment, because I've had people actually stop taking their medication because of it. But it's a stigma. This whole thing is talking about stigma. Well, there's a stigma that comes along with Methadone, and there's a stigma that comes along with Suboxone. So the question is, what is making you more functional? If you all of a sudden not all of a sudden, but if you're in treatment and you're functional and doing positive things and your life is turning in a positive way, that is a big thing for you. Now, we know what these medications and what these drugs do to the brain, where they really take over. They really hijack your brain. And so whatever led to your addiction, by the time they see me, they're usually out of control and they have no control over that addiction. These medications do give them control. So the other question is, how long do they stay on it? And that's a difficult question, because I'll give you an example I give to a lot of my patients. I had 1 week where I saw these 2 patients, and it was an interesting contrast. I actually saw them on the same day. One was a 59-year-old woman who'd been on heroin ever since she was a teenager. The only time she was off of heroin were for 6 years, not in a row, when she was in prison, because as she put it, she had this habit of stabbing people. So she always got off of opioids when she was in prison. When she got out of prison, she would start using again. And she actually kind of brought this up because she was afraid that I was going to try to wean her off of Suboxone. So multiple times she had gotten off of heroin. Every time she went back, she's someone who needs to stay on treatment, because she does not know how to function without being in treatment. And she will inevitably go back to heroin if she's not in treatment. So you look at a harm reduction strategy, and harm reduction for her is being on MAT basically as long as she'll stay on it. That same day, I saw a 19-year-old. He'd been using heroin for about 9 months, had all the usual problems that you get from using heroin. And he asked me the same question: how long do I stay on it? And for him, my answer was, kind of depends. Usually we like to have people on it for about a year or so before we talk about weaning down, because you have enough time for them to fix the maladaptive behaviors in their life that led to their addiction or that perpetuated their addiction. But for him at 19, do I say that at 80 he should be still taking Suboxone? Probably not. So for him, we kind of worked after a while on weaning down. I ended up transferring him to another provider, but he's someone who I think it's worthwhile at least trying to minimize the medication, if not getting rid of it. We do know there's a high rate of relapse. About 50 to 60% of people will relapse after they get off of MAT. Part of that may relate to our system, because it's so hard for people to get back into treatment sometimes. And so that's why I really believe in low barrier, that people need to be able to get treatment the day that they really need help. And that's why I do that in the ER. I've been doing the Bridge program for several years, and I haven't even done it as part of a grant. I've done it because I think it's important. And so I treat people in the ER. They come to me for help and they get treated right that day. And that's the way things are developing, and that's the way things should be in the future. And I think most communities are trying to develop that. So it's a complex answer. The answer is, it's not necessarily a crutch, it's part of treatment. It's not necessarily something that has to be lifelong, but maintaining their sobriety lifelong and making sure that they have someone to talk to and make sure they have that support is a lifelong kind of thing.
Thanks.
Easy to get me on the rant.
And along those lines, along the same line of questioning here, why is a crutch considered essential for some injuries, but not considered essential for treating an addiction illness?
Yeah, and Katie, that's a perfect response, because it's like saying, well, insulin is a crutch. Your pancreas needs to learn how to just make insulin for itself. You're using that crutch, so your pancreas will never learn how to produce insulin correctly when you eat something. You know, it's that one's a little more extreme of an example, but it really is. Again, so whatever led to someone's addiction, because I don't believe in, if you talk to people, you really find stories that you'll understand why they got addicted a lot of the times. That some people, you hear these horrible stories in their childhood, that they have this genetic susceptibility, and sometimes you can really see the addiction as a predictable response to things that have happened to people's lives. But however they got there, by the time they come to see me, their lives are out of control and they've completely lost control. So if you accept them where they are, you have to accept the fact that they're coming to you saying, I cannot control this and I need help. And we have something, a treatment that can help, that can potentially save their lives. If someone comes to me to the ER and they've had an overdose and we've had to give them Narcan, there's about a 5 to 10% chance they'll be dead in a year. So just to restate that, when they have an overdose, 5 or 10% chance that person, often a young person, will be dead in a year. And a lot of these are people, I'm seeing a lot of people in their 20s, 30s, but especially in their 20s that this is happening. So if this was your kid, your brother or sister, your family member, wouldn't you want to do everything you can to prevent that person from having that death? On top of that, when they're in the middle of addiction, their lives are absolutely miserable. Most people are not like, this is fun, this is great. By the time they're in treatment, their lives are ruined. They are miserable. Their lives are living hell. And they feel like they have no choice because their brain is telling them the only thing they can do to survive is keep using that drug. And so you can call it a crutch if you want to. To me, I call it a life-saving medication.
Thanks. And we have a hand raised, Makai. I think that's how you say it. I'm sorry, I probably said your name totally wrong.
It's okay. It's Micah. Hi. I didn't want to type in there because, yeah, I don't spell very well. A lot of my folks, a few of the people that I have worked with have said that they use meth because they're ADHD or have a really hard time focusing, stuff like that. And I know that Adderall is something that people have mentioned as like wanting to supplement. And in my mind, I thought, well, if they can get a hold of a medication that's over the counter and, you know, exactly like what you're saying, is that a bad thing? I'm just wondering your opinion, because I don't see that often used for meth, or is it just, I don't know, what do you think?
So that's a great question, Micah, because that's actually one that's brought up a lot in the addiction medicine world too. That I think there's actually ongoing studies looking at using stimulants like Adderall as kind of an MAT for stimulant use disorder. So if you look at the treatment of ADHD, when people are on appropriate medications for ADHD, they tend to have less drug use. They tend to have better functioning as well. So there is definitely a role for that. Part of it is someone who knows what they're doing has to diagnose ADHD. Now, or ADD, excuse me. Much of that usually means that it started in their childhood, but there is such a thing as ADD that starts in adulthood as well. So kind of separating that out and not just giving Adderall to people who are using methamphetamine, but using as part of a treatment program is actually a reasonable thing to do. And I've seen in the psychiatric realm that happening more. It's something where we have to very closely monitor that. And we have to make sure that it's not, I hate to say it's not an excuse because I'm talking about stigma and I'm throwing a stigmatizing thing, but it's really, when you talk to patients, you really have to kind of separate out, did they have ADHD type of symptoms before they were using? But in patients who truly have diagnosable ADD and are having issues with stimulants, there may be a role. It's just right now, the science is not really great. It's kind of tricky, but it's one of those things that's being talked about. And there is a justification if you have the right patient who's in recovery, who was using methamphetamines, for using appropriate treatment for ADD. So it's a great question.
And just really quickly, you also was talking about benzos and the difficulty of getting off of those. And I've had so many people struggle so heavily with that. Is there a specific thing that you can supplement for those kinds of addictions or to help with that? Because that's such a hard one.
Yeah, it's really hard. Anyone here who's a clinician who's tried to get someone off of benzos knows that's probably one of the biggest, most difficult things to do in medicine. I tend to do, so what happens is, what's interesting is off the high doses, they'll wean down pretty easily. And then people hit this threshold where they really have a hard time weaning down. The thing I've had the best experience is I've actually used gabapentin. It helps with anxiety. It helps, has a little bit of crossover. So I've done gabapentin as I'm weaning down the benzos. They have to have a good therapist along with it to work with that anxiety symptoms. Because part of the problems with benzos is benzos work so much better than anything else. So you take a benzo, your anxiety goes away, it's great. But the problem is, you know, you have to live your life and you're going to have things that are stressful. You're going to have things that are going to make you anxious. And so someone who's been using benzos chronically, nothing we do has that same effect as benzos. That's where I think gabapentin's probably, as far as medications, the best that I've been able to do. If I have a good therapist, I find that very helpful too on working with like meditation and breathing. And I'm kind of if you ask any of my patients, I'm kind of an endless loop of recommending meditation to people. And the biggest part is they have to be really motivated. It's so hard to do. I will say something out there for the providers too. In Shasta County, I had a providers group where we were actually meeting in person. And so those who are doing MAT, we would meet like once a month at my house and have some food and talk about the difficult cases and talk about MAT in general. I think I'm going to resurrect something like that. And I'm going to do it Mendocino, for my Mendocino and my Shasta County providers. Now that everything's on Zoom, I don't have to physically be there. So if you're interested, send me an email or just let me know. Sometime in the next month when things are a little less crazy for me, I'm going to try to start organizing that.
Wonderful. So the other question is where will the New Life Clinic be located in Ukiah?
It is where the old jail was, which I don't remember where exactly that is in Ukiah, but I'm guessing a lot of you know where that is. So they've been remodeling that building. I haven't gotten to see it recently, but I've heard that it just looks amazing for all the work that they've done too. And I would like just a comment here. Katie mentioned something about, made a good point too, as far as the medications for stimulant use disorder, that we're going to need to partner with psychiatry. And I think that's a good point because I forgot to mention that. And that's a huge part that on the telemedicine things that I'm doing right now, I work with a psychiatrist at times with the opioid treatment program. It's one of the things we've talked about at some point is, and this is just me talking, is we would like to somehow have a way to partner with psychiatric services. This is one step at a time because we're going through all the initial regulation stuff that we have to. But I think that's an important part of it too, is that so many of our patients have co-occurring illnesses or co-occurring disorders with their substance use. And so some people have underlying psychiatric issues. Some people have psychiatric issues from their substance use that gets better with the substance use. And it's really important from my perspective is teasing that out, of figuring out, which came first, and does treatment of the substance use disorder help the anxiety or mood symptoms, or were they self-medicating for their underlying psychiatric issues? And so it's an important part of what we do in addiction medicine is trying to figure out, which caused what, if it was the psychiatric part that led to their substance use disorder. And often the answer is really treating both and working well on all of this. I will say I'm a big believer. One of my criticisms of a lot of OTPs is they sit out on an island and they just treat the substance use disorder and don't necessarily communicate and play with everyone else. I'm from an FQHC background. When I worked with the tribe up in Reading, we had an urgent care, we had psychiatric services, we had plenty of that stuff to kind of treat the whole person. I'm a huge believer in playing well with others and treating the whole person as well. And that's hopefully something that we can work to do. And I'm more than happy to, if we have patients that we share, I'm more than happy once we get our releases and make sure everything's done to communicate, because I think that's a very important part of this treatment that doesn't always happen.
Thank you, Greg. I couldn't agree more. I don't have any other questions in the chat box. Are there any other questions from our participants? You can unmute yourself if you'd like. We have a few more minutes.
I guess everyone's quiet today.
I guess.
It's not hard to get me to talk more. So
I have another.
Say that,
I have a quick question. Sorry about that.
I do have another raise.
Okay. I was wondering, when you speak about low barrier, what does that look like for you?
So low barrier means, so let's look at our current model. I'll back up. It's a good question too, so thank you. Our current model is we tell people they come to the ER, they come to the hospital, they get out of jail, they go somewhere else, and we say, here's a pamphlet. Why don't you go make an appointment with someone there? And then they go and make an appointment, and then they say, okay, we're going to schedule for an intake a week from Tuesday. So keep using your heroin, but show up a week from Tuesday at 2 o'clock and don't be late, we won't see you. And then they see you, and maybe then they'll say, okay, we're going to schedule you with the doctor on Thursday at 8 a.m. Don't be late, and make sure you make that appointment, but keep using until you see that. I mean, it's kind of the way we do this treatment doesn't make sense. And so my belief in low barrier is truly low barrier, that someone can come and see someone in the ER, in the hospital, right when they leave from jail, where they have a place that they can go and they can say, hey, I need help. And then we say, I got help for you. So this comes from the model of what I do in the ER, because in the ER, people come to me and we will treat them right then. We don't just say, hey, here's a pamphlet, call someone, schedule an appointment. What we do is we talk to them, and if it's appropriate, we start them on Suboxone right there. And if you look at Gail D'Onofrio's study out of Yale, and Gail D'Onofrio did a study where they looked at either the usual care, which is just handing people a pamphlet and say, okay, good luck. And I think Dr. Herring talked about this as well, because he's been my mentor with a lot of this. Or here's some Suboxone, we're going to get you started right here. Go to this clinic tomorrow and they'll take care of you. Twice as many people actually went into treatment and stayed in treatment who actually got started in the ER. And so I'm a big believer in really wherever we can, if we can get them started on treatment right there, we have a much better chance of success. So again, this is going back to what I'm doing with the New Life Clinic, because I'm trying to design something which is what I really want it to be. We will be open 7 days a week. So instead of the ER trying to call and make an appointment, they can just say, show up at this place tomorrow. And in my experience, because I've worked in a lot of different settings, that makes all of the difference. That we have to be flexible enough to see people, 7 days a week. We can say during this time you come there, we'll see the patient, and then we can get them started on treatment as soon as possible. one of my other jobs, I work with Bright Heart Health right now doing telemedicine, and I do a low barrier clinic at one of the needle exchanges. And so basically they'll be at the needle exchange and they'll say, hey, you want to see a doctor and talk about treatment? And that's what I do. And, you know, it's a quick history and telemedicine history and physical, but a lot of times I'm starting them on medications right there in the hopes that they will then get into treatment and stay in treatment too.
Perfect. So we are out of time for our Q&A session. There are a lot of good questions here, though, that we can roll into our next session. And when we enter into breakout after we listen to Libby, I do see your hand raised, Marianne, if you want to go ahead and say something, and then we can go on to our next session.
Sorry, I didn't put my hand down. Hi, Dr. Greenberg. My name is Marianne Cox-Gould. I'm the supervisor for the 3 Adventist sites with the Bridge program. So it's great to hear you speak, and I'm looking forward to working with you. That was my main question was, you know, if this was going to be low barrier, what the hours would be to be able to get people in, because my patient population are patients coming into the ED. So I think you answered those questions.
Well, good. I'll speak to it anyway. So thank you, and it's good to meet you. So I have worked with the Bridge program, and I was doing Bridge before it was cool. I did it before there was actually money behind it, just because I was motivated and I wanted to do it. And I did it. I worked with the Bridge program in 2 hospitals. The first one was me trying to do it, which I realized that changing physician behavior is incredibly difficult. And I basically hit my head against the wall for 3 years. And then at the other hospital in Mercy and Reading, we got a substance use navigator, Angela. And Angela is amazing. Angela is awesome, and she makes all the difference. Because remember, those relationships make a huge difference. So she gets the relationships with the patient, she calls them, she talks to them, she makes sure that they follow up. And so she's really made all that difference. So the Bridge program, me as a physician, I'm really not all that useful. It's actually our substance use navigators that really do all the hard work and that really make a difference. And so, Marianne, when we're up and running, we'll set it up for certain hours, and I'll know more details when we're actually up and running. That should be in early July. We're still waiting on some of the regulatory stuff, but we're anticipating early July to start. And then we'll say, you know, certain hours that they can come 7 days a week, and then they can be seen, and then we can get them treated as well. So I'll have more details as we get closer.
Thank you. Thank you, Dr. Greenberg, for your presentation, the Q&As, everyone participating. Really appreciate it. This is a great starting point for our discussions and connecting and creating that mapping service throughout the county. Next, we are going to move on, though. Sorry, everyone. But our next presenter is Libby Guthrie. She is amazing. She works in the field of HIV service provisions for 33 years. She has a master's in clinical psychology and a doctor of education and counseling psychology. Hepatitis C education, prevention, and care coordination for 20 years, specializing in harm reduction case management. CBT and narrative therapy, along with specialty work for persons with co-occurring disorders, dual diagnosis, and persons with SMI. Welcome, Libby. We're so happy to have you here. This is great because now we can see the full spectrum of treatment and where it starts. At least that's my opinion.
It's mine as well. Yeah. Hello, everyone. The same disclaimer as last week. I hope I do not have a coughing fit. I will do my best. Anyway, so I wanted to talk about harm reduction as it relates to the psychosocial issues with homelessness and infectious disease risks. So gonna do a quick history overview. You know, harm reduction's been around a very long time. It was actually, it started more than a century ago as a thought process, if you will, on how to address alcohol dependence. It was actually considered for use in 1926 as an approach to opioid dependence. And that actually included the possibility of medically maintaining the addict. So that would have been by using heroin, using opioids that would sustain the person, sort of like Greg was talking about. You know, it's still harm reduction because it's a medication that it doesn't have to be sought, doesn't have to, you know, you don't have to live and die for it. It can be part of your day. And then methadone was actually started for use in clinics. I believe it was 1968. I had a friend who actually was one of the first people in the methadone clinic in Berkeley back in 68. So the use of the term harm reduction began officially in 1987. And it was around, it was designed to reduce damage and infectious diseases that were caused by risky behaviors. And that's sexual and injection risks, because we actually really started talking about harm reduction in terms of HIV risk when we began talking about condoms in the early 80s. I mean, really talking about them. Next, please. So again, we've heard this description several times in the last 3 weeks, but it is meeting people where they are, quite literally, and also figuratively, if you will, and where they are at the entry into the system. So in terms of people in recovery, you know, the old paradigm is when you're ready, come and we'll help you. Well, this is just come, not when you're ready, because we don't have a program for you. You're going to make that program. And if that program just means you're going to be safer while you're using and less likely to die, then that's where you're going to be. And we're not going to push you anywhere that you don't want to go right now. So it's based on compassionate pragmatism instead of moralistic idealism, which is where many of us go. You know, oh, if they could only do this, or oh, if they could, their life would be so much better, yada, yada. Life can be better even when you're still using. So behavior change is a very incremental process in harm reduction. Personal power to shape your own behavioral goals. And then providers just understanding the power of the non-judgmental relationship, how it increases people's self-esteem and actually their self-efficacy. Just coming to a syringe services program can make somebody feel like they're doing something powerful. They're doing something that's going to help them and the people that they are around, the people that they're using with, and it can be very empowering, and it's the first step for many people. Again, pragmatism falls into accepting that mind-altering substances are inevitable in our societies. We know that people have been using for 4,000 years plus, and people are drawn to things that make them feel better, that take away pain, and our societies are focused on that in so many ways. And we spend our time demonizing portions and places that people use and the types of things people use. But, you know, again, if you need insulin, are you shamed for it? No. If you need an aspirin because your head hurts, are you shamed for it? No. So we're the ones that attach all this stigma to the use of drugs and or alcohol. Focusing on the harms is just the reduction of harmful consequences in spite of continued use. And again, that's a powerful thing in itself. Prioritization of goals, prioritizing goals with a focus on the immediate reduction in drug-related harm. And it may or may not lead to the eventual long-term goal of abstinence. But if it does, that's great, that's wonderful, and it's probably going to stick a lot better because it was done at the pace that the individual needed it to be. Next, please. There's a flexibility of interventions or options. There's no prescription for interventions. Many treatment facilities have prescriptions. This is what you do first. This is what you do second. This is what you do third. Those are people who are ostensibly ready for treatment. Some are, some aren't. Some do well with that prescription. Many people don't. So it's very, very important to harm reductionists to know that people have the flexibility to do what they need to do at the pace they need to do it. Autonomy is the client's use is viewed as a personal coping strategy. And at McCavan, we view the use of substances as a coping strategy. And it may become problematic, and it probably will become problematic, but the issue is it generally begins because there aren't better coping strategies. These are the easiest coping strategies to find. You can find this way to cope in 5 minutes anywhere. And it's just, you know, that's how it's viewed in a harm reduction sort of paradigm. And evaluation, health and functional stability of the individual, and also the impact on the greater community is always taken into consideration. This is an example in housing, how the housing ready paradigm is different than the housing first. So in the housing ready, which many people are still practicing, even though housing first is really the way that HUD has defined it for us for multiple years now, is that there's still a propensity to require treatment first, clean time, compliance with rules and restrictions for a specific period of time, and the circumstances are outlined for the client. So McCavan has tried to house people under Housing First for a couple of decades, but we were also working within a system that required our clients to jump through many hoops. And we had a bit of a waiver, if you will, for our HIV clients because they had established that as a fast track infectious disease, and some of our clients were allowed to get into housing prior to having completed treatments. But it was quite a battle for a very long time. So Housing First really came to HUD generally probably less than 10 years ago. And a lot of agencies have had to shift their focus into putting people into housing before they're ready. And what's ready is all those things on the left. But actually, when you're looking at Housing First, you're looking at home as being constancy for an individual and security for an individual and a place that they can shape their identity after they're already housed. There's a day-to-day routine that can be established. And when people are told they have to jump through all these hoops until they are going to be rewarded with a house, sometimes it's not so easy to even find that person or help that person because there is such inconsistency in their life on an ongoing basis. And then it's about having control over your own life and feeling that you're free of surveillance. hepatitis C treatment issues. We've been connecting people to Hep C treatment for about 20 years, but we had to fight with different FQHCs and private physicians and different protocols that did not allow for people who were not clean and sober. They wouldn't even be considered for treatment. They had to have 6 months clean time, and some physicians required up to 2 years of clean time. They had to have housing stability. And there was a lot of concern about patients not showing up, and that they couldn't take their medications. So McCavan decided nearly 20 years ago that we would help people, and we would try to work with the clinics and physicians in our community to let them know that we would do everything in our power to help that person make it through treatment, regardless of their housing circumstances, even if they were in jail, whatever the issue. Well, in 2015, things changed in California, and the recommendations were that we treat all active injection users, all people that were at the highest risk and or had the highest likelihood of spreading hepatitis C, because they were still using. So we had a physician that approached us in 2016 and said, I'll help. I'll treat everybody regardless of their use. Now that's being adopted in many places, and our lovely Ace Barish has come to help us here at McCavan treat people who are still actively using. And we're seeing people who are using syringe services to stop reinfection. So if they are infected, they're getting treated. If they're not yet infected, they're going to stay that way. But reinfection can happen if there aren't syringe services available and people end up having to share equipment. So the connection between the syringe exchange and the Hep C treatment program is much like our syringe exchange. And now we have a very low barrier MAT program that we are just starting at McCavan, probably under the same grant that Greg was talking about with another SSP up in Northern California. And then the supports are in place. We have staff whose job it is to coordinate everything to do with the hepatitis C treatment. Kristen's our clinic coordinator, and she's helping people navigate, helping people get their medications, helping people stay on their medications regardless of where they are staying. If they're out on the street, they're in the jail, or wherever, they're still going to be treated. So. And some of the comorbidities of people who are at risk, when I was doing HIV care specifically, and I was doing a group for HIV positive women, interestingly enough, there were 8 women in that group, and every single one of the women in that group had been sexually abused as children and adults. And there was almost a matter of factual kind of expectation that somehow they didn't deserve anything better than that. If you're walking around with a mindset like that, it's very, very dangerous, and it's very risky. The people with HIV also, 43% of them suffered sexual abuse as adults, and 41% are or have been in physically violent relationships. These statistics account for risky behaviors through 4 mechanisms: using substances to cope with abuse, mental illness that's due to abuse and ongoing traumas, recycling of traumas, trauma triggers, riskier social networks overall, being in situations that feel very familiar, and then poorer sexual adjustment. And then when I was mentioning that normalizing abuse, it really threw me for a loop, because the group discussed this kind of thing like almost like it was expected, and that really saddened me. It made me think, what has happened to you as a child that somehow you thought that you deserved that, and that was very disturbing for me. Anyway, so HIV treatment issues have always been an issue for actively using people and people that are homeless with HIV. And I know we have done a lot of work in the world helping people manage their HIV, even when they are homeless and or unhoused, and they're living in really sketchy circumstances. But it isn't impossible to have adherence, again, with the proper supports. So you want to keep people's CD4 counts up, their viral loads down, obviously deal with the dangers of any opportunistic infections, and have supportive people from clinics and nonprofit organizations that are there to make this work for people, because there were times that our folks were refused medications even though they needed them very badly, because the risk of poor adherence and then getting resistant viruses and all these things have been an ongoing debate. And I hear that debate still today. What can we do? And then, of course, helping somebody deal with side effects and the determination that they can stay healthy regardless of their circumstances. At McCavan, I've mentioned this, but harm reduction informs all the services in all our agency programs, because we're serving people living with substance use disorders, severe and persistent mental illness, infectious diseases, chronic homelessness. And I mentioned we're currently treating Hep C, and we are about to embark on very low barrier MAT. We are working those details out as I speak. So we shall see how that goes and how quickly we get moving. And we often deal with people who others consider too challenging. We're not afraid of that. We're very happy to serve people that might be considered too challenging to others. It's an alternative to the current overarching system that still wants people to play by the rules. And the rules for engagement with us are: don't do any harm to others. Don't, I mean, it's not like a free-for-all. It's, we have expectations about behavior and not being dangerous to oneself or the staff or other clients. But those are really the rules of engagement for us. Harm reduction philosophy views abstinence as an eventual goal for most persons, but it mainly focuses on achieving specific behavior changes that lower the individual social and community risks, as long as the individual is continuing use. Again, this is some information. This is a good decade and a half old, but when I was doing my dissertation, this jumped out at me, that with HIV positive people, the prevalence of moderate to severe mental health disorders was measured at 54%. therefore putting them at pretty high risk. Those included major depression in 20% of the population, adjustment disorders in 18%, and substance use disorders in 74% of the HIV positive population at that clinic. And then personality disorders in 26%. And that is totally consistent with what we see at McCavan. This is about shifting frames of reference over time when you're being served by people who embrace you and really care about you as a human being, regardless of what you're doing to damage yourself or to not get with the program or whatever. And during research I did over several years, there were so many people that entered the system in what's called the chaos narrative. Everything's wrong in my life. I'm worthless. I've never done anything right. Nobody loves me. Nobody cares. And often people will go through these stages. And restitution is a narrative that is sort of like, if I do things this way, this thing will happen and that'll get better. And if I do things this way, I know that I'll feel better. And that's okay too, because it's a step beyond the chaos narrative. But the quest narrative is the one that some people reach, and that narrative doesn't interest itself in whether they're doing something right or they're doing something wrong. What it is it's future focused in a way that's very, very positive. Like, it doesn't matter what happens today, even though it's a one day at a time, it's still in a way future focused, because it says if I just sort of live in the moment and I have dreams, I'll just move towards them. And that's what we want. That's what we want to see in the clients we see: the sense of inclusion, normalcy, a sense of support, and a sense of autonomy. And that's the end of my spiel. What we're going to do is put up a slide. It was actually a poster presentation, but put up a slide, and it's got a bunch of boxes in it with things, basically sayings or concepts or whatever. Mm-hmm. And what we were hoping is that how many breakout groups could we have?
Well, we've got, I can't see, 30 participants. We could do 5 groups, or 6 groups of 5, or 5 groups of 6.
Okay, yeah, if you have somebody that can be in every one of those rooms.
We can float around.
Okay, so what we're hoping is that you'll take, each group will just like pick maybe 3 of these comments or precepts or whatever, what have you, and talk about your acceptance, or your questions, or your things that don't make sense to you, and just kind of come back with things that we want to discuss, maybe to close out today. But in breakout groups, to just pick, and you can pick any, but maybe 3 of them, and just discuss amongst yourselves what those statements mean to you, how they work into your personal view, or how they might be in support of your working environment, or very hard to achieve in your working environment.
Okay, I'm hoping this will still share the slide to everybody, but I'm going to make 6 breakout rooms. And let's see. Okay. Going on a wild ride, everybody. All right. Okay. I'm going to open them. I think this works. Okay. I think this is sharing tolerant. There they go.
Okay, so is there gonna be one of us in each group? You can manage that somehow?
Yeah. I
Like
need to
Joe can be
move.
one.
I think we're in. Trying to see here. Okay. Sorry.
And Lasara's gonna help us?
Yeah. Joe's in room 5. I need to move.
Grace,
Yes.
hey, this is Sean. Joe is outside with a client and I don't know what to do. Do I push this?
It's okay. Can you see the slide?
Yeah, don't worry,
Yes.
maybe Kristen can be down there with you.
Well, she's in her office,
Oh.
but I need her in a breakout room.
Oh, I got you.
So I'm moving. I just moved Kristen. Oh
Do
no.
I push join?
Is this Derek?
To
To the right.
Okay. Let me. Somebody's not joined here. I'm gonna. Okay.
Not this one? It's the one on the right, unless he took it with him.
Oh, Joanne's in there by herself, so I need to move some people around here.
Yeah, that's his.
Move to where's Joanne? Joanne's in room 5. There we go. Is this working? I don't understand what's happening here.
Oh wait, I'm still on.
Hi, Grace.
Hi, Libby.
Hi, Libby.
I'm in Libby's account, but it's me and Libby.
Okay.
Oh, okay. So
Can
we
you
go
guys
groups
still
of
see
5
the
or
slide?
6?
Can you guys see the slides okay?
No.
I
Oh.
did not see the slide.
Ooh.
Yeah.
See, that's what I was talking about when we got here. I was like, I wish I could have looked at that slide some more before. we got
Oh
here. And now I'm kind of like, what are we supposed to talk about? Because I didn't really get to read it.
no.
It's up there for like 2 seconds and then poof, gone.
Hold on. Let me try
I
something.
took some pictures, but yeah, if you need me to send you my.
Let me see what I can do here. Oh God. All right. Well, we're still in here. Let's see.
Hang tight.
I knew something like this would happen.
We always have some snafu.
I'm just gonna send all the questions to all the rooms. So it should come through in the chat. I just sent a message to everything.
Oh,
To everybody.
They can click the chat.
Hopefully it's working.
Okay.
Do you guys see it in the chat? I don't know. This is
Not yet.
oh God.
I see what you're typing in the top, but when I click on chat, I'm not seeing you put in anything at all.
Oh, okay. It's supposed to come up. It says I broadcast a message to all the rooms. So that's what I'm doing. I'm just broadcasting these.
And then they can click on the link.
No,
Oh,
they have to read the
okay.
each of these. So I'm
That's
just
fine.
sending them out.
It's so tiny.
Zoom is so
It doesn't help that we're using like a little maybe 11-inch laptop.
it's really hard to
We'll just let maybe.
I don't want to freak you guys out. Here, let me read this here.
I'm
about how
sorry.
close I have to get.
Honestly, there's so much discussion around harm reduction anyway. I bet everybody's doing okay, but I'm just like, I feel bad. I thought when I shared it, it would share to the breakouts. Good God.
No, it's quite labor intensive.
This Zoom business.
That's too small.
Okay. Well, why don't we talk about just in this breakout room because you've got me and Libby here. So if there's something you want to ask her, if you want to talk about one of these, you know, things that I've been broadcasting, if you will. Oh God, crisis is calling me.
You can't.
I know. Which one do you want?
Oh, hey, cool. Thank you, Joanne. Something I can read these.
Oh, medication assisted. I hope that Greg actually takes that.
What's the top?
Can you guys see the slides now?
No.
No, you
I had
can't.
to send,
Oh, I see.
had to send
Okay.
copy and paste of
Okay,
everything. So I
okay.
don't know what's happening. It's okay.
Every time you type, it's written on the top, but it's so little.
Yeah, way.
Great.
all the information you just put up there, I just tried to read. I honestly couldn't make out a single letter. It was so small. I got my glasses on my work desk.
Okay. So maybe we can discuss this one. Harm reduction reduces the incidences of overdose, infectious disease, and harmful self-stigma. Did you have any thoughts on that? Any opinions, thoughts?
I actually agree with that
Question.
whole statement. Like it's pretty clear, and I'm in agreement with all of that. There's not really questions I have about that because that's how I honestly feel.
Yeah.
Well, no, that's good, but
Doing what we're doing.
it is true that some people really grapple with that. But you know, I mean, comments like, if they want to use drugs, let them die. If, you know, there's definitely a continuum, if you will, about people's honest feelings about drug users and how they consider or think about drug users. And it's not politically correct sometimes to say that, to share those feelings. But there are people that have no problem with sharing that. And I've heard it all. So it's just good to be able to say what you feel about statements like that. And he just did. Mike just said, I'm in agreement with all that. But it's quite possible that some people aren't.
Same here too. I agree. I mean, if some of my clients, you need to be more kind of like not assisting, like more educating them about what kind of medication they're taking. If they're aware of that, and I would agree that it reduced the incidence of overdose. I mean, all the statements it's more kind of like, it's more kind of like avoiding harmful. I mean, knowing what kind of medication, educating yourself. So also not only that, like for more kind of like while you're educating yourself, what the side effects and all that. But not only that, that's just, it makes you more aware of not harmful yourself. Yeah, that's what I'm going towards.
And you can use motivational interviewing perfectly in a situation like this, because what you're asking that person to share is, what are the positive things? What works for you using drugs? Well, it makes me feel calmer, or it makes me not feel pain anymore, or I just kind of go numb when I'm triggered by my traumas. I go numb. So those are all positive things in that person's viewpoint. So you're acknowledging the positive pieces of why they use. Okay, then what are some of the things that you consistently run into that are negative about that use? And you can really open up a really great discussion by just asking, what are the reasons for your use? Because, well, I just want to. No, I mean, let's talk about what kind of pain it helps with, and is that physical pain or psychic pain? And it can really enrich a conversation where the person understands that you actually really do want to understand what the positive aspects of their use are. You know, we ask those questions all the time. So what does the alcohol do for you? Makes me forget everything. Now that may not seem like a highly positive or functional thing, but it actually is if you don't have other ways in your toolbox to address your pain. So then you're saying, well, what are some of the other things that we might be able to do? What are some of the things that you've been interested in your life? And you can kind of build on these other places that don't have anything to do with drugs, but are also calming and make a person feel better. I'm sorry.
Yeah, I agree on that, because one of the example that one of my clients, every time I see him, he always use cannabis. And it's a really good example. I asked him, I noticed that, you know, every time I see you, I can smell you use cannabis. And he said, you know, Joanne, I feel like for daily basis, I've been using cannabis. It helps me to focus. It helps me to get up. It helps me because one of his goal also to gain a little bit. So it helps him to eat more food you use normally that he eats. So yeah, it's kind of like it's knowing what the client's gonna, it's giving, not only that he's giving me explanation, it's kind of like, hey, it's a good way, it's a good way for your positive reinforcement that, hey, you can use that for your appetite, increase your appetite. So
and actually, if you're thoroughly harm reduction, when you're having that discussion, it is actually a harm reduction measure that that person is using a cannabis, a substance that's now legal for adults, than it would be for them to be using heroin, something that they had to work really hard to get. And or completely blow all their money on, or all these other things that are just sort of practical. But that person was able, that client of yours was able to tell you, these are positive things that I feel are beneficial. Now, if he ever wants to get off of cannabis, then the trick is, what are some of the things that are going to help replace that sense of well-being that he has when he's using his cannabis.
And we have a lot of clients that, especially if they're homeless and have anxiety about the doctor, for example. I mean, chronic pain and being on the street and in the elements, often they do turn to heroin or meth. Libby also brings up a really good point in a lot of her presentations, that often women who are homeless use meth to stay up all night to avoid being assaulted. So when they're using it for survival, that's a very hard thing to just say, stop doing it, right? Even when we get people housed, you know, that's not something that, okay, I have a house now, so I'm going to stop using drugs. That's not really how it works. And so that's also why Housing First is such a great model in harm reduction, because giving someone a consistent place to be where we can find them, where we can help them. You know, they may still continue to use in their apartment, but we're helping them have a safer environment to live in, and it's a place that they have security. And, you know, based on the hierarchy of needs, if you're constantly in survival mode, you'll never be able to figure out why you're using. It's just to cover the pain, right? Or survive. So Oh, I'm supposed to bring everybody back now. I think.
Oh, well, good we didn't pick 3.
Yeah, sorry. Zoom is not my, okay, I'm closing them all.
Libby, thank you for your presentation. That's really helpful.
Absolutely. You're very welcome.
Okay, we will see you.
We'll see you back in the
Back there.
big room.
Yeah.
Bye. Okay, we're leaving. So my whole plan was foiled.
Yes, yes, it was. I have to say that was not enough time for us to get to know each other.
Sorry. But I thought we could, because nobody could see the slides, if we came back at 1:20, we could talk about it and ask questions, because my whole plan did not go as planned, which is the story of my life. But here we're back. So moderator, take it away. I should not be allowed to touch a computer for the rest of the day.
Yeah, somebody moderate, man.
Oh, well, you know, I think that it would be important as well to talk about what we talked about in our groups.
Only
I don't know what
we wanted to do that too. I just
LaSara, can you start, my dear?
Definitely, it would be a pleasure. So I was in the room with Geraldine and Haley, and we talked about harm reduction. We talked about a number of things. We covered a lot of ground, actually. And one of the things we talked about was harm reduction in a mental health perspective, like how to integrate harm reduction into the mental health frame. We talked about harm reduction as an umbrella, with abstinence as one of the elements of harm reduction, and how sometimes switching the frame in that regard can make it easier to create open and trusting communication with our clients, because we're meeting them where they're at and not expecting them to achieve abstinence at a level that is untenable for them in that moment. And we talked about the idea of meeting them where they're at, but not leaving them there. Those were the main themes that we went over, I believe. Or if Geraldine or Haley want to add anything, feel free.
Thanks, LaSara, really. Anybody else that was in a group?
I can say something for a moment, Libby. I had a small group. It was me and Joe. So we were, we ended up discussing kind of like the, you know, the first thing on the slide here, just how we both are in, you know, support of everything harm reduction based, but also that there's a necessity for maybe safe consumption sites. We also, you know, and we hope that we can get there, but it's still going to take a lot of pushing, like just like how we got to where we are now. And then we went into other stuff that we're talking about, like how prevalent fentanyl is, and how it's taking just more Narcan and naloxone or naloxone to reverse it.
Absolutely.
And someone had asked earlier about fentanyl strips in the chat. If you need fentanyl strips, McCavan has them, and I can also make kits up. You know, if you need them at your organization or you want them for your clients, but we have them.
The testing strips for people's product.
I need them.
Okay.
I got you, Micah. Whole person cares on my list. I'm making a little care package.
Anybody
I'll
else?
go ahead and share for our group if we have time.
Al.
Yeah,
Yeah.
that's you, Al.
Yeah.
Okay, that's me. We had a great group. We had Lisa and Andrea and Adrian, and it was a pretty lively discussion that went right up to the end. You know, we talked about policy changes and how policy changes really can support harm reduction. Lisa mentioned how decriminalization of possession in Washington State and looking at the impact of that. We discussed reducing stigma and reducing barriers, and regardless of what somebody does, whether they return to drug use, and and allowing them to come back without judging them and casting doubt on what it is that they're doing. We talked about stages of change and how it's a natural process of going through the stages of change, and how, when we talk about resistance, how resistance is more of an issue for the counselor, and how when we describe something as being resistant, it's being judgmental as well. And so, really taking an MI approach to it. And then I think, let's see, lastly, we talked about the impact of trauma, both personal as well as generational and institutional trauma, and how it's so important to be able to address that in such a way that it allows people to not forget the trauma, but rather to be able to manage it, to be able to deal with it, and recognize the impact that it's had on an individual, the behaviors and some of the choices that they made, so that they can move on. So it was a really productive group. Thank you.
Yay, great. I think we have 3 minutes left. So
yeah, we also talked about the motivational interviewing as a way for people to express what that substance does for them at this time in their life and in the past, and once again, the pros and cons. What are the benefits? What are the problems? And really connecting with that person in a respectful way that says, I understand why you're using, and you want to mitigate the harm, and we want to do that in the way that best suits you. So that he's focused on that in ours. Anybody else?
Yeah, and so hi, my group was Mariana, Micah, and Dr. Hanukkah. I was hoping they would chime in. We had a great conversation as well. We talked about policy changes and the services that are in the county. We also talked about linkages and how we can connect, and having a mapping service, and hopefully having that hub that we keep talking about throughout the series of where people can find services. But not just that, but also know the little niches of each provider. So is this provider friendly? Do you have to be totally abstinent to be a part of this program? Where are the low barrier programs at? And also, is there any, the psychology part of it as well, not just treatment, and behavioral health combined. And so those were some of our conversations. Anything else, ladies? And we got to know each other, which was really cool, because I didn't know. I've heard of whole person care, and I've heard about the rural clinic across the street in Ukiah. Of course, I didn't know anything about them, so we got to introduce ourselves as well.
Cool, great, cool.
Yeah.
Thank you, guys.
Good times.
I'm gonna stop sharing now, and I'm gonna let Buffy finish.
Close us out, girl. Close us out.
Or Joanne.
Okay,
Or
well,
Joanne.
I'll close you out.
Or Greg,
Yeah.
or Al.
So I just want to close you out in a good way. I want to take a little time and thank our ancestors, the people who came from this land traditionally. There are 10 federally recognized tribes in Mendocino County. I thank them all, and thank the ones that aren't federally recognized as well. our Indigenous people. We owe them a lot of gratitude for being the stewards of this land for all the time before we got here, in the capacity that we are in now. So we Kotu, thank you, all prevailing spirit. Thank you all for joining us, and we look forward to hearing from you. If you have any questions or comments, please contact any of us. You can get a hold of us through the SafeRx website. Many of us are listed on that website, and it'll link you right into the other websites. And thank you so very much.
Thank you,
Thank
guys.
you, everybody.
Great job, Buffy, Libby,
Thank you.
Thanks,
Greg,
everyone.
Grace.
Bye.
You all did an amazing job.
Thank you, Buffy. Thanks,
Sorry for
everybody.
the breakout room snafu.
You guys all
I like the
really
breakout room
well.
snafu. That was fun.
Hey,
I got to go rogue.
I thought it would share to everyone, and that did not happen.
No. But y'all adapted really well.
So
Right?
yeah.
I was all,
I
let me
know.
see.
And then I kept thinking, I said, "Oh, you can see it," and they're like, "No, I can't." And I was like, "Oh God." So
Yeah, the whole IT thing just
sounds about right for me. Okay, let's all go eat lunch, and I'm gonna. Thanks, guys.
Right?
You all take
Bye.
care.
Everyone
Thank
have
you.
a great day.
Great job.
See you later.
All right. Bye.